Good afternoon, everybody, and welcome to the Maine Public Health Association's annual meeting. My name is Ed Miller. I'm the retired director of the American Lung Association here in Maine, and also like with my other panelists here today, an alumni of the Maine Center for Disease Control, and very happy to welcome all of you to this session on. This is not a session on politics in public health. I want to make that clear. This is a section on the politicizing of public health. Public health has always been firmly entrenched and inseparable from politics, but we're really here to talk about something that has risen its head in terms of politicizing public health. We're going to talk a bit about the historical context because this is not the first time that this has happened. But there are some differences, and we want to talk about those. We want to hear some of your concerns, some of your thoughts on this topic as well. In preparing for this, I couldn't help but think about the classic public health story about John Snow and the cholera epidemic in London in the 1850s, which actually was almost a decade or more than a decade before we actually knew anything about germ theory. And at that time, John Snow, who many consider to be the father of epidemiology, addressed this by figuring out where people were getting sick. And he took the pump handle off the Broad Street pump, and the epidemic subsided. Now, I can't help but think if John Snow were alive today and pulled that little trick off, probably before he got back to his office, there'd be somebody out there organizing a citizens to restore the handle on the pump. And that's kind of the situation we find ourselves in today, is that politics and public health has always been with us, but we're really talking about kind of a different animal here. I'm very pleased today to have two panelists here who have a great deal of experience in this topic and strong ties with this issue and public health in Maine over a number of decades. And so I would like to first introduce Paul Keuhnert. Paul's the president and CEO of the Public Health, let me just make sure I get this right, of the Public Health Accreditation Board. And he'll be speaking to us first. We're going to do about 3 to 5 minutes of opening comments, and then we're going to pull out some topics to discuss, and also throughout, if you have questions, please use the discussion board to post those, and we'll get to those as well. So, Paul, I'm going to turn it over to you right now.
Well, thanks so much, Ed. And it's really, really great to be here this afternoon with everyone, and particularly with you, Ed, and with our good friend Dora Mills, and really looking forward to the conversation. So this topic, as you said, Ed, politics is part and parcel of public health. And that's because really so much of what we try to do to affect population health is through policy. And we also depend a great deal on public resources for the work that we do. And then another aspect of kind of the long-standing part of politics is that, it's through politics itself, really, that we kind of negotiate values when they're in conflict with each other. And so we typically do see conflict, in public health, oftentimes kind of between individual rights and the common good. And that's something that kind of goes back to the very beginnings of our country. So, as you said, this is not new, but it is different now. And I think the ways that it's different is really in the degrees of politicization. And a couple of things that have come to my attention as we kind of look at it nationally from Public Health Accreditation Board. We're seeing, an incredible amount of social and political labeling. And oftentimes it's pretty stark. We see an escalation of the language that's being used, and we see threats and physical violence happening. And I think we saw this Actually, in the Sunday paper, there was a story about threats to school nurses. And we've seen this across the country. Kind of the third area that we've seen is the firing or the forcing out of public health officials. And now fully 1 out of every 5 US residents has had their local public health official dismissed or fired or forced out during this pandemic. So it's over 300 local public health officials. And then another dimension of this escalation is in the legislative and judicial arena. So we now have 26 states that have put restrictions in place around public health authority, and another 3 states that the Supreme Judicial Courts have restricted public health authority. So this is really a very different environment than we've experienced in some of the other major public health issues like HIV/AIDS or tobacco. So I look forward to talking about these things. Just as we think about it, I have been thinking about what's different, and I would kind of point to 2 things. One is social media. And if we think back to some of the other earlier controversial areas in public health and politics, we didn't have the extent of social media that we do now. And the second thing is, I think we have to own up to the fact that in politics right now, we do have a anti-democratic, small d democratic, authoritarian movement going on that really is seeking to restrict democracy. And I think that unfortunately, this pandemic and public health measures like masking and vaccination have become the fodder for this political movement. So with that, I'll turn it back to you, Ed, and look forward to the conversation.
Thank you very much, Paul, giving us some things to think about and already kind of spurred a question on in the discussion box that we'll get to as we move forward. It's my pleasure now to introduce my friend and colleague, Dora Mills, who's the Chief Health Improvement Officer at MaineHealth. And many of you also remember her in her term as State Health Officer and Director of Maine CDC. So Dora, welcome, and looking forward to hearing your comments.
Well, it's great to see you and Paul, all colleagues for many years. And I wish I could see the audience, but anyway, it's great to at least see Ed and Paul and see Becca's name there. So I know I just so miss seeing everybody. I just hope next year we can all be in person. And I know being a hiking person, I'll be hugging everybody, I think. So we all miss that, but it's Becca, and my hat is off to Becca and the MPHA for doing such a tremendous job on putting together this conference this year. I know I was tuning in and out yesterday, and it was just really much more engaging than I thought it would be, because I've gone to a lot of Zoom meetings, but not one that was so well organized as this. So thank you so much, Becca, for your leadership and everything that MPHA is doing to help us through this pandemic and also put on this conference. So of course, some of you may know that I did a lot of research on the 1918 pandemic in Maine years ago, I think in the late 90s or something. And it was really interesting because the politicizing, and thank you, Ed, for acknowledging that none of us can pronounce the noun there, was very, very evident. So at that time, public health authority in Maine was at the municipal level. So what happened was every municipality had by statute, had a board of health that the public health authority was delegated to from the state. And so it sounds really great, except that it was very, very politicized. So at the time, our roads were not as well developed. So our roads were really like the rivers. A lot of towns grew up along the rivers. And that's why we have a lot of twin towns or twin cities along rivers. So we had the Lewiston, Auburn, Biddeford, Saco, Fairfield, Waterville, Brewer, Bangor, all those kinds of towns. And it was quite interesting to see how differently towns that were right next to each other, particularly across the river from each other, handled the pandemic. And the boards of health would, for instance, sometimes close all the schools, all the theaters, everywhere in the fall of 1918, when the pandemic of influenza started coming into Maine. And then across the river or next door, they would say, oh, opportunity here, business opportunity. So they stayed open. And everybody would flock there to go shopping and go to the theaters and things like that. So they did have silent movies, I think, back then, but they did have some movie theaters. What was really became very politicized was the closing and opening of the churches, as we had communities such as Lewiston and Biddeford that had seen a large number of immigrants from Quebec, from French Canada, come in the prior 2 or 3 decades, who were primarily Catholic. And yet sometimes for instance, in Lewiston, the Board of Health was still was not primarily, at least names were not French names, and they closed the churches there. It was very controversial because a lot of the people said, well, wait a minute, you've kept in Lewiston, for instance, they kept the factories open. They had large factories where a lot of people had come down from immigrated from Quebec, for instance, to work in the factories, the woolen mill factories and others. And so the Board of Health in Lewiston, for instance, kept the factories open, but they closed the churches. And the Monsignor at the time in Lewiston gave this tremendous speech that was in the Lewiston Sun Journal newspaper at the time, imploring the Board of Health and saying, you've kept the factories open when people are really close together, working really close together and sharing germs. Germ theory had evolved, I think, since John Snow by then. And then but you've closed the churches, the one place where people can go. So many people are dying, and people need to go on Sundays and have some healing and hear some words of hope. And they're clean because they dress up for church, and so they clean themselves, and they're not so close together, or don't have to be. But the Board of Health insisted that the churches be closed and the factories stay open. So just one small example of how the politicization of the pandemic of 1918 happened at the local level. And in Portland, the same thing happened. And some of you may know that the case of keeping the churches open, the bishop in Portland took it to the Maine Supreme Court. He said the Board of Health should not have the authority to close churches. It's a First Amendment, blah, 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 right. And went up to the Maine Supreme Court. They heard it in a hurry. And the Maine Supreme Court decided with the Board of Health. They said they do have the authority to close churches. But the bishop was a very political person, very strategic person. He went to the Board of Health and he said, okay, I lost my case, but you guys, Maine General, which is now Maine Medical Center, but the precursor of Maine Medical Center, Maine General, was overrun with patients. And he said, if you open the churches, I will open a new hospital within 2 weeks, and we will take all comers, including people with the flu, influenza. And they agreed. And that's the birth of Mercy Hospital, why Portland has 2 hospitals. So sometimes the politicalization is not all bad. Sometimes there's some fruits, unexpected fruits that come out of it. And I know I work at MaineHealth, but we're very, very, very grateful that we have Mercy Hospital in Portland as well. So that's just some examples from 1918, and mainly to show that, it's politicalization of public health is nothing new, and it was pretty raw in 1918. The newspapers were full of a lot of anger. They didn't have maybe social media, but they had the newspapers, which many, many read. And I know Paul and Ed and I have a few scars from the AIDS and HIV epidemic from the early days there, which was heavily, heavily politicized, and so on and so forth. So I think the good news is this is nothing new, so we shouldn't be too shocked, but it's certainly disturbing. And I think we've got, as we discuss things, hopefully we'll come up with a few action steps that we can also take. So thank you. It's great to see everybody.
Great. I'm going to, we've got a number of questions that have come in, and a number of themes that are rolling out here. Paul, you touched on the social media influence, and there's another question dealing with efforts to subvert public health authority, and in some ways these are somewhat of a reflection on the lack of trusted sources. The idea that public health is not based in fact, but based in belief to some degree, and that there's a sort of a public forum out there that really has kind of a life of its own. And I'm wondering if, Paul, if you could comment on that, and then Dora, I'd be interested in your perspective on that as well. And the questions that people are asking, a number of the questions are, what can we as public health professionals do to address this? And I would add, to address this and to not inflame it or make it worse. I mean, I think that also is a concern.
Yeah, I think it definitely is. And I think the comments and the questions kind of point to some of the central things that we really need to wrestle with as a public health community. So let me just offer a few thoughts. First of all, I think we need to kind of acknowledge who we are and where our comfort zone is. And I would just say, I'd be the first to admit that we're kind of science geeks, we're policy geeks, and in public health, we like to include everything, all the complexity of issues, and we try to be as inclusive as possible. And that's not a bad thing. But in this case, we're in an environment where there's a lot of simplistic and single issue and very emotional kind of appeals going on. So I think we have to start with a way that maybe is outside of our comfort zone. And that is that we really do need to start from a place where we acknowledge our vulnerabilities and our common humanity, and kind of lean into the conversation around what do we really value as a community? What do we really care about? What kind of things are we trying to get to? And talk about those things in plain English. So, for example, can we talk about the fact that we'd like our communities to be better places to live for our children and our grandchildren? Is that something that is, probably a shared aspiration, a shared value? I think it is, but is it a way to kind of get into this conversation at perhaps a deeper level, and not start with, well, the science shows or the evidence says? I think we need to start with something that is much more basic than that. So I just kind of put that on the table and see what you and Dora have to say.
I think that's a really great pearl to start with, Paul. I think you're right. We do need to start with common ground. And I think it's, I'll be honest, I think it's easier said than done. And I'm sure you would agree with that, in this day and age, I mean, I'm sure many out there have struck up conversations with our friends, our neighbors, our colleagues, our people we know who are just really, maybe against masking, against vaccines or whatever. And you try to find some common ground and move from there. And it is an ideal. I agree, and it is a strategy we should all try. But I have found it increasingly difficult the last few months. And so I have a number of friends I grew up with in rural Maine, for instance, give an example, who were really, who were very much against a lot of the masking and the vaccine and all that. And it's been tough. It's been really tough to have conversations and finding the common ground. I think we can easily agree on the really high level, we want what's best for everybody or the best for our communities, but then it quickly devolves into mandates versus choice and that kind of thing. And it's been challenging, I think. But I agree with you that the overall, we do want to at least keep in mind that common ground and always strive to find it. I'd say there's a question here about social media, and I think that those of you who are comfortable on social media, not everybody is. I think as public health professionals, we have to be on it public health professionals, if we're comfortable on it. I mean, not everybody's comfortable, not everybody can. I'm sure Paul is an executive director of a national organization. You probably have to be a little bit careful. As an executive at MaineHealth, I have to be careful. I'm not speaking for MaineHealth as a system, but I do to participate in social media on the pandemic, on public health science. I'm fortunate, I'll be really honest, when it gets very politicized on my Facebook posts, people will start arguing about things. I've got just a wonderful cadre of friends, probably some of you there, thank you so much, who come on and start commenting, because I can't, as an executive at a health system, start going and going toe to toe with somebody who's arguing about things. But what I have found is that I've a number of wonderful public health colleagues who are out there who will kind of chime in and start doing things. And I think we have to have a presence, because we'd like to think that we just stay pure and just say, here's where we're going to start, and with some common ground, and here's where the science is going to lead us. But unless we're having those conversations and some of those myths are debunked, it's the social media presence is so strong in our lives, and whether it's Facebook or LinkedIn or TikTok or Instagram or whatever it is, Twitter, it's there. And I think unless we're out there as a public health community putting out what the science is, why we believe it, going to Paul's point about it's about protecting, and promoting the health of our communities, of our families, of ourselves, and our whole state and our whole society. So I think we have to participate as much as we're able to. I think it's where the battleground is right now in many ways, and not to say that we have to battle exactly, but if we're not out there as a voice, other voices will be predominant. So I don't know if that hopefully answers all the questions, but we could.
I think we'll continue. We'll continue to have pieces of this roll through it. I'm sure as we continue on this discussion. I do want to call attention to the question, and I think it's a really good statement in the discussion box about the legitimacy of distrust that exists in historically marginalized communities. And while we can look back at many public health and healthcare successes, there are also no shortage of activities that are less than trust building, to put it mildly. And while we'd like to think of those as being back in the old days, they are very much with us still today. I find it, in a way quite helpful, but in a way quite sad that some people, it took the COVID-19 for them to recognize that we have health disparities in this country, and they start talking about it a bit. It's now time to stop talking and start doing something about it. But I think that's important that that trust level in public health may not be uniformly shared across the country, and in many cases with very good reason. We've had many examples of that, even right here in Maine, between environmental issues and other kinds of issues that have affected different populations in different ways. And so I'm not sure if either of you like to comment on that.
No, I think that's right, Ed. And I think we, part of this in terms of how do we move through this moment is taking ownership of that is ours with this. And so, a legacy of mistrust is certainly something that we need to own. And the solution is not to deny it or to try to get away from it, but really to kind of say, well, let's talk about this and let's talk about how we can build trust with our community members now and today. So part of that is certainly owning what's happened. Part of it is how we conduct ourselves going forward. And I think the other thing that's really important for us to remember is that, the vast majority of people in our communities actually agree with what we're doing. So we see that in terms of vaccination rates, we see that in terms of public support in polls, et cetera. And I think that doesn't give us license to be arrogant or just say, well, we can ignore the 25 or 30% of people that are not on board. But it should give us some level of confidence that, we're not kind of just talking to ourselves, that the things that we're trying to do that people do appreciate and understand are having an impact on their health. And we need to find ways to invite voices other than quote unquote experts into making the case. So, quite frankly, a minister or a rabbi and their opinions about vaccination are going to probably carry more weight than mine or yours with certain community members. And it's really important that we find ways to, bring everybody's voice into the conversation.
Yeah, and I completely agree. And I think that, and I agree with Ed that we, this pandemic has really ripped the Band-Aid and showed the wounds of a legacy of disparities for many generations, and very challenging so across the country as well as here in Maine. I think that Maine has done quite a good job of stepping up and engaging with a number of particularly racial and ethnic minority populations. I mean, I'm not saying it's ideal or anything like that, but I think it's relatively done a relatively good job. And particularly you see that in the data. And I think when you look at the data right now in Maine, we're actually seeing a group of that are, I think, are marginalized that we didn't predict a year ago. And that is rural whites who are, and particularly those under 60. You look at our vaccination data, and it's correlated very much with the Delta surge. So where there's low vaccine rates, there's a very disproportionately impacted Delta surge as an example. So yes, our vaccination rates are some of the highest, second highest in the country. You look at the whole population of Maine, all ages, 69% are fully vaccinated. That's amazing. Cumberland County is 76%. But our rural counties are in the 50s. So you look at Piscataquis, Somerset, Oxford, Franklin counties, they have the lowest vaccination rates in the state, and they're all around 53 to 56, 57%, much lower than Cumberland County. And look at where the Delta surges has been disproportionately impacting. We've had the highest incidence and test positivity rates of the entire pandemic in Maine have been happening the last month in our most rural county, Piscataquis County. And this is looking at 28-day and 14-day rates. So this isn't just a blip, because it's a pretty rural county. So you can say, well, what if just a few people got it one day and the rates went up? Now this is going back the last month and looking at averages. So and they also have one of the lowest vaccination rates in the state, with those other three counties that I mentioned. And right now, Franklin and Oxford counties those incidences are increasing to very alarming numbers. And when we look at the biggest surge before the Delta surge was last winter, and it was December, January, before we had vaccinations widely available. And you look at the counties that were mostly impacted were more urban ones, such as Cumberland. So Cumberland County had the highest pandemic activity last winter. But what's going on right now in rural Maine puts that winter surge, it leaves it in the dust, that the incidents and the deaths and the hospitalizations and the test positivity rates in rural Maine, particularly where the vaccination rates are the lowest, are much, much higher than what we saw anywhere last winter. So and then if you look at our data by statewide data by race and ethnicity, actually we've got our data, our vaccination rates of whites with a full vaccination, a full final dose is 53%. And then Native Americans, Blacks, and Asians actually have higher percentages than whites. And if you look at by age, it's also, you look at so in Cumberland County, 95% of people 50 and older in Cumberland County are fully vaccinated. That's amazing. 95% of people 50 and older in Cumberland County are fully vaccinated, but that falls to 70%. So age is, again, one of the, the biggest risk factor for severe disease is age, but only 70 to 75% of those 50 and older in those 4 rural Western counties are vaccinated, fully vaccinated. So, a year ago, I don't think any of us were really predicting that it was going to be rural whites who were going to be the places we needed to really focus on. And it's not all access. So, I'd say, well, maybe there's less access to vaccine. Maybe that's some of it, but it's certainly, we know from the experiences we have at MaineHealth and with our colleagues and in some of those neighboring counties that we've been providing lots and lots of vaccine clinics in those areas, and just people are not interested. So it is, but to get back to the point that Paul and Ed were mentioning, partnering with people who don't always look and sound like us. And we've been, partnering with evangelical church, conservative churches in rural Maine, partnering with people who are, much, maybe very different politically than we are. It's tough. It's not, so it's a big challenge. And I know a number of people have been trying. I know I've got some friends from social media and public health out in rural areas who are trying to do that. But if we had to do it over again, I wish we'd done it a year ago. It might have been easier. Now things have gotten so polarized; it's really tough to do that. But anyway, it's a real conundrum because we do have these big pockets of places with low vaccine rates and people very resistant, and that's where, unfortunately, tragically, the surge is disproportionately impacting as well.
One of the comments is looking at the role of public health workforce, public health workers at the local level, the regional level, the sub-state level within the state, and kind of noting that we had a system, as you well know, of community coalitions statewide. We had a robust public health nursing system, and these were largely made up of people who lived and worked and were known in those communities. And what kind of impact do you think that's having? How can those folks that are working locally be best used? And are there some things we need to really take a look at in terms of our public health system as a result of where we are right now?
Yeah, absolutely. I mean, I think not only in our state, but across the country, we entered into this pandemic with at least one of our hands tied behind our back, right? Because the public health workforce, those frontline public health nurses, community health educators, folks that are, known and part of the community, school nurses, all of those positions, so many of them have been lost. And so I think part of what the long-term strategy here is certainly rebuilding that workforce and doing it in ways that really do value and incorporate community members from the diverse communities in Maine as a major part of that workforce. So we have to prioritize that. I think the other thing, though, is that we need to think about how we as a public health community can get engaged in meaningful ways in the political issues. Because quite frankly, the stats that Dora pointed to, part of that is being driven by an ideology, by a news media, that really has an interest in promoting that, and it has a point of view. And I think when I think back on my days in the Chicago area, dealing with HIV/AIDS in the early and mid 80s, we were dealing with significant stigma, discrimination, all kinds of terrible attitudes and things that were being voiced about people living with HIV and AIDS. But it didn't gain the kind of political traction that this has gained. And I think really the difference is social media and this organized national political movement. So the remedy for that, certainly long-term, is to have a long-term strategy and build back that public health, community health workforce, stay engaged with people on that kind of frontline community level. And also we can't neglect the politics. And as citizens, as residents, we need to become more active and lean into these issues. And again, I'm not saying this as a national organization, but really as a resident of Hollowell, Maine, and caring about my community. And if we're going to be able to really grapple with these things, we have to change the politics.
I completely agree. I think we have to have those dialogues on an ongoing basis, and I hope people are. I hope people are inspired to run for the school board, especially after hearing about the school board meetings in some of the places in Maine in the last few weeks, because public health authority is a mixture of local and state. The state doesn't have the ability to just click its heels and tell everybody to mask and do whatever unless there's a state of emergency. So getting involved with the town, your town council or town selectmen and school board and places like that, and reaching out to partners that don't always agree with one's politics or one's life viewpoint, I think is extremely important, especially now. I mean, this pandemic, we're moving into a time of endemicity, moving towards an endemic. So this is going to be with us for a while, and we can't predict where this is going to go. Nobody predicted the Delta variant, so who knows what's going to happen. This could fizzle away over time, or we could have more variants that cause more surges. And but regardless, it's going to be here for a while. So I anticipate that we're going to want to be masked in indoor places, and when there's surges of influenza or COVID-19, for quite a while. I mean, some Asian countries started doing it during the pandemic of 1918, and they're still doing it. So they learned something from 1918 that we didn't apparently learn. So and looking at the ventilation of our schools and indoor places where people are tightly together. Looking at, just other safety measures around respiratory viruses. So, the Jon Snow story precipitated, there was a ripple effect of changing how we thought about water and drinking water, keeping drinking water and sewerage completely separate. It took until the early 1900s for Maine to pass laws that regulated drinking water, but it was a result of the ripple effect of Jon Snow. And I predict that with this pandemic, we should be seeing a ripple effect of being much more cognizant about respiratory viruses and how they're transmitted and what we can do to mitigate them. But it's going to involve policy. At some point, we have to be looking at what is the ventilation systems in our places where we work and we go to school, and what are the masking policies? At what point do we say, we should be probably masking indoors in schools or in workplaces now because the disease rate has gone up to X, and all that. I mean, the Maine CDC and the US CDC, state government and federal governments are not going to do all this for us. It's really going to be at the local level that we're going to be implementing this. So I think that we need to start, getting much more involved as public health professionals in our local policy, local, state, and federal policy making. So, which includes forming relationships too with a lot of different types of people.
So we've talked a lot about the pandemic, and just a couple of thoughts here. There in many senses right now, the pandemic is also that shiny object that everybody's focusing on while other things are crumbling below us. So I mean, it used to be in many states, they would look to certain states as bellwether states for advocating advances in public health, and California obviously was a big one on the tobacco area. And it seems now that we've got states like Texas and Florida who are deputizing vigilantes dealing with abortion, telling business, how ironic that the governor of Texas is telling businesses what they can and can't do. I thought that was something only the Democrats were accused of it. But the idea, I guess, I'd like to just get to is kind of framing up these kinds of public health issues and the difference that kind of context and language makes when we address these issues. We many times talked about public doesn't know what public health is. It's so hard to get across what public health does. Well, there's a whole group of people that now think they know what public health does, and they don't like it, and they feel like it's an anti-liberty, anti-freedom profession, and that's kind of the box they put around it, and those things matter in terms of that belief system, as we talked about earlier. I just interested in where you go with some of this. How do you do you continue to try to convince policymakers that they might want to change their mind, or do you organize and get them out of office and get somebody else in that has a different viewpoint? Just some thoughts on that as we move into an election year.
It's probably both and, right, Ed? I mean, I think we need to look at elected policymakers in terms of what their actual track record is. And, there's a really interesting study that was released yesterday from the Journal of Preventive Medicine that really looks specifically at a COVID-related policy on the state level. And what it showed was that, and this probably isn't a huge surprise, but on looking at across the country, that as a whole, Democratic governors were more strict in COVID policy related things like masking and social distancing and closing early in the pandemic. And on the scale of the study, they were about 10% more strict. What that did was result in an 8% decrease in COVID cases in those states. And, the bottom line is this has real life consequences. That's estimated to be 22,000 deaths that have happened, did not need to happen. In other words, if everybody was strict about the recommended COVID policies, we would have saved at least 22,000 lives. So that kind of shows the real world consequences this study did of the politics, because it's straight up partisan politics. So again, I think as public health professionals, with our values, with our worldview, we do need to kind of, lean into this a little bit and look at how we can become more effective in working at the local level on up through the state and national level. And I think this is the moment to remember, the challenges are significant. There is a significant minority out there that is very vociferously opposed to all of this. And there is a solid majority that actually now does understand more about public health. And unlike the minority, actually appreciates public health and what we're doing and the values that underpin it. So I think we have to, really kind of find our way into this and really continue to have these conversations and work together to make the changes that we need to. So probably by both supporting elected officials that are supportive of public health policies and working to get rid of politicians that are not and replace them with those that are on.
And I'd like to also segue us to what next steps that and that's part of what you're talking about, Paul, some next steps. And I think there's also, after the H1N1 pandemic, we did do a number of surveys and focus groups. And actually, I was just looking the other day at the after action report from that. And oh my goodness, I know we didn't have the polarization then that we have now, but so much of the lessons learned, you got to just take out H1N1 and put COVID. It's quite an interesting document for the fact that it's we're still learning these lessons, aren't we? But there are important lessons to an after action process, and I would suggest that that organizations, where you work, to do some simple after action. We did one at MaineHealth after the, I think last fall, after the first few months, and then after the winter surge, and then we'll do one again as this surge starts to quiet down a bit. But just, and after action doesn't have to be a real complicated thing. It could just be say, hey, we as an organization, and whatever organization you work with is, what went well and what can we learn from? I mean, it's just really two basic questions that I think can be very helpful, and particularly doing that with focus groups, if that's appropriate, with people in person, but also through anonymous surveys. So you get what really people might be too shy to say, but they're going to pour it out maybe on a survey. So I think that all of us should be involved in one way or another if we're able to, with an after action process. And then another one is really figuring out, we've kind of alluded to this quite a bit, is growing allies with the unexpected people or organizations who may have an interest in this. So Ed did an amazing job 20 some odd years ago, realizing that the smoking in workplaces, that there was a natural ally there, not a natural ally, but an unexpected perhaps ally with unions. And Ed did a great job. I remember reaching out to unions across the state and saying, you really should be concerned about secondhand smoke in the workplace. This is a really dangerous thing and dangerous to your members. And a number of unions became advocates for smoke-free workplaces as a result. Maybe it was 30 years ago, actually. I don't probably getting the decades mixed up.
I won't say.
Yeah, it was too many to count, maybe. But anyway, so I think, the same thing, I think we have to figure out, with knowing that vaccination, masking, distancing, ventilation, those are all our tools that we have to, and testing. So yeah, vaccination is the most protective layer, but vaccination, masking, distancing, ventilation, and testing, those are the 5 tools, the 5 layers of protection. So as the fall, eventually we'll get cooler this fall, and we start putting on those protective layers, those are the layers we need to be concerned about. And how do we address those across our society? And who are some organizations or people who may be natural allies, who may help us bring those folks who are really maybe against masking and vaccination mandates right now, but even some people that are in the middle somewhere, like unions. I mean, maybe we can, in some religious faith organizations and others, who we could help bring along to help us reach a broader audience and have a stronger voice. So there's a couple of next steps I can think of? I know Paul and Ed, I'm sure you've got some ideas too. And
Yeah, I think those are really great ones, Dora. And I guess what I would add is that there are a number of things happening on a national level right now that we here in Maine will be able to leverage. So one example is, FAAP is part of a coalition with some philanthropies, as well as some of the national organizations like ASTO and NACCHO and APHA, working on a project that's called Public Health Forward. And Public Health Forward is being coordinated by the Bipartisan Policy Center. And its purpose is to come up with some actionable policy recommendations that states and localities can take to modernize and I would say transform public health. So what have we been learning? What did we know before, but what have really come into sharp relief during this pandemic? And how can we take this moment and, oh, by the way, all the federal resources that are in this moment and take them and move them into an agenda that policymakers can act on. So this Public Health Forward, actually the task force is a bipartisan task force. Just to give you an example, it's headed by retired Republican Governor John Kasich from Ohio, and it has an equal number of Democrats and Republicans on it that are elected local and state officials. So they're having their last meeting today. We're anticipating that report's going to come out probably toward the end of November. And it's something that as a public health community, I think we can look at and leverage and bring to our policymakers kind of as a potential action agenda. And that's the kind of thing that I think, in addition to the great recommendations that you were making, Dora, that, really seeing ourselves as part of a national movement as well, to learn from this moment and grow from this moment, and really take advantage of the new resources that are available to us.
Great. So we have about 10 minutes left in the in this session. I want to thank our Zoom viewers here, because they've really sent some very good questions, and we haven't been able to get to all of them. I'm going to just go through a few of them, and Dora, you and Paul might want to comment on, pick and choose which one you might want. One person talked about this was actually very interesting. There was a comment made that we're really not talking about politicizing public health. We're talking about the politicizing public health issues. The public health it could be a bit confusing. And I thought it was interesting. They said, well, maybe it's just like semantics, but no, it isn't. And because we talked about this, I think that's a very important thing, that words in fact do matter. And politicizing public health, that kind of a context could actually make things worse for public health, if that's what people think we're doing, is choosing sides and dividing up and those kind of things. I thought it was a very good comment. Someone mentioned what role, if any, could local health officers have in these kinds of public health issues, particularly ones where trust is extremely important. And I know the work that MPHA has been doing since the pandemic began, really, and working with a number of local groups throughout the state. There's a lot of interest, there's a lot of talent, and all of us in MPHA live someplace. And so the degree to which we get involved in our local community, local boards at a health center or a hospital can really make a big difference. Someone mentioned that while we have all the fancy social media, local newspapers still have some sway in some communities, and they're not always the most accurate when it comes to some of these issues. So that's something to also respond to, I think, is what their message was. Respond to and take part in that, monitor some of the comments, because many of those anonymous comments, seem to have a lot more weight than they're given. So those were a few of the comments that people had sent in. I don't know if any of those grabbed your attention or you'd like to make comments on.
Yeah, Paul.
Dora? Paul?
We're looking at each other.
What was
and
public
it's-
health? The other
We're
one
looking
I
at each other.
neglected, Paul,
Ellipsis.
was
SPMAC.
the other one I
I
was public
neglected,
health
comma,
training.
The other one I neglected
Oh,
is
wait,
training
I'm
period.
hearing the closed captioner.
SPMAC.
Are you guys hearing the closed captioner?
I am hearing the closed captioner period. Are you guys hearing the?
Okay. Sorry. Okay, I just couldn't. I was like, oh my gosh, I'm hearing myself twice.
Yeah.
Okay. Yeah. Yeah. I think I think in public health too, I do think we sometimes suffer from being too polite. Paul and I, oh, you go first. Oh, you go first. No, I didn't mean that kind of politeness, but I think when I look back to the AIDS epidemic, I started medical school in 1982, so it was right at the beginning of the AIDS epidemic, and really, and I know Paul has a long history with it as well in his early career, and it was really the people who were, went out there and fought for science and health, and they had to get loud. President Reagan didn't mention the word AIDS or HIV for what is like 5 years or something. Mm-hmm. And Woodrow Wilson, the president during the 1918 pandemic, never talked about it publicly. So anyway, so this is not an uncommon thing, but it's, I think, looking back on the HIV/AIDS pandemic, which is also a pandemic, the public health, it wasn't actually the traditional public health people so much. I mean, there were a number of them, including our own Lonnie Graham, who were very, and Paul actually in Chicago, I think, who became very strong advocates. But they were a lot of the people who were the allies of public health. A lot of the gay community, for instance, really had to go and stand up and get very, pretty aggressive in their fighting for health and for science and for their rights. And I think that we have to realize what's at stake here. I think we have to also, start getting really, many of us are trying to, but I think we also have to come together as a community and really advocate hard. This is going to be really, really a tough few months, if not a couple of years, of trying to change the culture around some of these things that people are very angry about, like vaccination. And again, a minority group of people who are very angry about it seems to be, but still that those loud voices oftentimes win if we're not also, out there and loud and together and strong, advocating for the science based approach to this. And I just also want to one more quick thing, which is that some of the wins in tobacco had to do with pointing out the secondhand effects, and people, and I think that's a very big analogy now, because people are like, well, it should be my choice whether to get vaccinated, blah, blah, blah. It's like, yeah, but you know what? Just like with primary smoking, people said it was a right to smoke. Well, it's not your right to make other people sick. And vaccination is very similar in that if you don't get vaccinated, and you don't mask, you're making other people sick. So that secondhand effect message as well is something I think we need to be much stronger and louder on. So, so I would just, one lesson I think from one of the prior pandemics, of at least the HIV/AIDS one, is that we've got to, this isn't going to end in the next few days or weeks. We're got to continue to be strong advocates, as I know that MPHA and all you members of MPHA have a long history of doing, and I thank you so much for that. But we're going to continue to need you to do that. So thank you.
So I think part of it is just kind of building on what Dora said, keeping in mind that this is a long-term issue, and it's something that we need to think about for the long term, building back the public health workforce, staying engaged, and leaning into the conversations around what our values are, and how to make sure that all the voices in our communities are heard.
So we are in a country that prides itself in its individuality and individual rights, and so there will probably never be a time when there is not back and forth dialogue and debate, and that's a good thing. It's having it grounded in science and having the public's best interest in mind. I think that we're all looking for, and I think that that's kind of it's not to eliminate debate, and so the scientists rule. And I guess that's just kind of the final note I'd like to make. And I'd like to again thank the panel members and thank the many participants that took part in this today.
Thank you, Ed. This is Becca just chiming in. I want to thank you, and I want to thank Dora and Paul again for the really thoughtful discussion, and to everybody who participated in this session. There were so many awesome, very thoughtful questions, and we appreciated your high level of engagement. So thank you to everybody. I do just want to remind folks to please complete the session evaluation. It's under the feedback button. And up next, we have a 20-minute physical activity break. Ellen Thorne from Healthy Community Coalition of Greater Franklin County very kindly put together some suggested movement and stretch breaks. And we hope you can also, maybe get outside for a bit. We'll see you back here at 1:30 for our next session, broadening our understanding of ACEs, tools to prevent, address, and heal trauma by focusing on community determinants of health. So with that, we will hopefully see you soon at 1:30. Thank you.